is headed by Dr. Vijay Agarwal, who is the president, Dr. Santosh Sen Gupta, who is the vice president, Dr. Lalu Joseph, who is the secretary general, and Dr. Naren Sehgal, who is the finance secretary. This webinar is organized by the Quality Professionals Wing of COW. It is one of the three main verticals of COW and is dedicated to nurturing the professional needs of healthcare workers, especially those responsible for quality in their own institutes. The COW CQE webinar is a 3-hour virtual conclave conducted on the last Saturday of every month. These sessions are aimed at educating healthcare workers in India and elsewhere on the best practices to adopt and implement with the goal of improving patient safety and quality of care delivery. The theme for today's session is Perioperative Anesthesia Safety for Risk Reduction. The Indian Society of Anesthesiologists, that is ISA, and the ASCO are the knowledge partners, and they have supported us well through the program towards this program. On behalf of the Governing Council of COW, I welcome everyone to the program and look forward to an engaging session from all the speakers. It's my privilege to introduce the organizing chair for today's session, Dr. Anita Shirley Jocelyn. She is the professor and at the Department of Anesthesia at Christian Medical College and Hospital, Vellore. I request her to take the proceeding forward and introduce the organizing team and the program. Over to you, ma'am.
Thanks, Dr. Subin. Good evening, everyone. And as the organizing chairperson, it's my privilege to welcome each and every one of you for this webinar on perioperative patient safety. And as Dr. Subin had mentioned, this is a part of the series by the CAHO professionals. And we are on the 29th webinar. So the theme for this webinar is perioperative anesthesia safety for risk reduction. So we all, as anesthesiologists, our aim is to provide a very high quality and a safe care for our patients who are undergoing anesthesia and sedation every day in our ORs as well as in outside OR areas. But does it always go as we want? Because we are working in an area where lots of risks are prone to happen. And even, I'm sure all of you agree, there are patients who are ASA1 who are very healthy. They come for very minor procedures, but sometimes even they can end up having any adverse event or a crisis situation. So when we work in such a high risk situation, how do we provide a safe and efficient care for our patients every day, or how do we improve the quality of the anesthetic care? And also, if you look at our work pattern, we are not the single treating physicians. We are a part of this multidisciplinary team and we work with plenty of people. Sometimes we see them for the first time. It can be medical people or it can be surgeons as well as, nurses and technicians. So when you're working with such a large team, what are the technical as well as the non-technical skills which are required for everyday functioning for us, which is going to improve our patient safety? And also, if you look at the resources which are available across our country, you take a corporate setup or a huge, teaching institute, as well as compare that with a single clinic or a mission hospital in a rural setup. If you look at the resources available in terms of the personnel available or the equipment or the other facilities, how are we going to provide care in these less resource setups with the same efficient and the safe care to all the patients? So now these are some of the questions which will be in the minds of us, and these are the different aspects which are going to be covered in this webinar. And I would like to thank the rest of the organizing team for helping us to come up with this webinar topics, and also identifying faculty who will be doing justice to these topics and sharing their expertise, which is going to be of use for us. And at this point, I would like to introduce the organizing secretaries. We have Dr. Rahul Deshmukh, who is a very senior person in this quality management. And currently, he's a medical director and head of anesthesia at Medicare Orthopedic and Spine Hospital in Dubai. And also, we have Dr. Darshana Rathod, who is the additional director in the Department of Critical Care Medicine at Sir H.N. Reliance Foundation Hospital, Mumbai. And I also would like to introduce our the person who is going to host the webinar, Ms. Debatta Das. She's a quality head at the Tata Trust Network Hospitals. She's been actively involved in this quality management program and for the implementation of various ISO, NABH, NABL, and GCA standards. So once again, a very warm welcome to each and every one of you. And I hope that each of us can take back some new message at the end of this webinar to improve the quality of the anesthesia care for our patients. So I would like to hand over this to Ms. Debatta Das now.
Thank you so much, ma'am, for the wonderful introduction. With this note, good afternoon, everyone. And I would like to introduce our first speaker, Dr. Muralidhar Thondebhavi Subbaramaiah, who is our first speaker for the topic patient safety in anesthesia, perioperative safety. And I would like to share his brief profile with you all. He is MD Anesthesiology, Fellow of Royal College of Anesthesia, Certificate of Completion of Training CCT Anesthetics from UK, Fellow of Faculty of Pain Medicine of Royal College of Anesthetists from London, UK, and he is also MBA in Hospital Administration. Currently, he is associated with as a consultant anesthesia and pain management of Apollo Hospitals, Bangalore. And he is member of National Executive Committee, Academy of Regional Anesthesia, India, reviewer of Indian Journal of Palliative Care, reviewer of Journal of Anesthesia, and he is a distinguished clinical tutor of Apollo Hospital Education and Research Foundation. He is also an associate professor for Apollo Hospitals Education and Research Foundation, and he has a teaching experience as faculty for various international and national scientific workshops. And he had also authored a book of 2 chapters, textbook of pain management of 3rd edition of Paris Medical Publisher. And he is also active member of professional societies like Royal College of Anesthetists, Faculty of Pain Medicine of Royal College of Anesthesia. And with this note, I would like to welcome Dr. Muralidhar to take the first session. I welcome you, sir, to carry the session forward.
Thank you. Thank you very much. So, good afternoon, good morning to all the delegates, ladies and gentlemen, boys and girls. I'm sure many boys and girls are listening to this talk. Now, at the outset, I would like to thank the CAHO organization and also the Indian Society of Anesthesiologists for coming together and having this 3-hour session on patient safety in anesthesia. And I would like to thank the organizing team for giving me an opportunity to speak in the next 20 minutes about the perioperative patient safety in anesthesia. No conflicts of interest when it comes to this talk. And what I'll be doing in the next 20 minutes is talking about the overview of perioperative safety. Why are we talking about safety here? Why is anesthesia and safety so important? And as an anesthetist, what are the different phases that we can impact safety? That is the pre, intra, and post-operative phases. What are all the human factors? Just an overview again as to what are the human factors that can play an important role. What about technology? What about education and training? So let's start with what is a complex system. Now, we are talking about risk reduction in this session. So we need to understand what is a complex system. Now, to give you an example, a few of the complex systems that we can see around us. One is the weather. Second is probably a cockpit in a flight where we can see so many buttons and knobs, and definitely it looks complex. But more complex than all this is the human body. Now, if you take complex systems, the advantages whenever we deal with a complex system is the whole is greater than the sum of the parts. Like we know our body, there are a lot of different parts, but the whole is greater than the sum of the parts. And adaptability. There is a resilience in the system which leads to adaptability. But the drawbacks are plenty, that there can be things which emerge in a system. Now, we saw COVID kind of ripping through the entire world. And this is just to show how something emerging out of a complex system can cause chaos. Next is relationships are non-linear. That is, things can go spiraling out of hand in case things start becoming a little bit problematic. Then we have these critical transitions where things change from something very benign to something very complex and which can lead to disasters. So medicine is actually a very complex system, more complex than any system that we know. And how do we know that it is complex? Now, we know that the measure of complexity is based on the ease of building a computer simulation. And we know that to build a simulation which mimics the human body is extremely difficult. And in the same lines, we have something that we need to know when we talk about risk, that is something called as L-time. Now, L-time is based on a Russian scientist called Lyapunov, which is a mathematical concept of complex systems. That is, it is the time period before which a system starts to exhibit chaotic behavior and starts breaking down. Now, to give you an example, if we take our universe, the L time might be in millions of years, because we know that the sun is going to rise tomorrow morning. We are very much sure the moon's going to come in a very nice cyclical way, and definitely the universe is not going to break down in the next 5 years. When we take weather, we know that we can predict to up to days. We know that there is some predictability that things are not going to become from directly being sunny to having tornadoes. But when it comes to a human body, the human body can stay stable for years, or as we have seen in a critically ill patient, can deteriorate in minutes. So the L time is something that we have to know as anesthetists when we see patients. What is the L time of this patient? How bad or how chaotic can the system become now that I've seen this patient? So if I see somebody with a aortic aneurysm which is bleeding, I know the L time is probably hours that the system can break down. If I see somebody with an osteoarthritis, I know that the knee is not going to break down in the next month or two or something on those lines. So this is something that we have to bear in mind when we talk about perioperative safety. Now, why are we worried about this L time and why are we worried about the safety at all? Now, this was data which came out in 2016, and it looked at what is the causes of death in the US. And we can see that the third cause of death here is medical error. So we as healthcare professionals in hospitals can actually impact the third most common cause of death, that is a medical error. And the pooled rate of preventable mortality in this paper, which came out in 2020, was 3.1%. And if you look at how anesthetists are impacting this is actually a graph which shows how the anesthesia-related mortality is decreasing from 1940s, as you can see here, and it is coming down. And this is a pooled data from across the world. And we can see that the anesthetic-related mortality is actually on a decline and we are becoming safer. So is anesthesiology the best model for patient safety? Now, this paper, which was by Dr. Gaba from Stanford, talked about anesthesiology actually leading the way for safety. So he acknowledged that anesthesiology is a leading medical specialty addressing patient safety. Multidisciplinary foundations like the Anesthesia Patient Safety Foundation in the US and the recently launched Anesthesia Patient Safety Forum of India, they are the key vehicles for promoting patient safety, but we still have a long way to go before things become really safe. So coming to what can we do as anesthetists? Now let's take an example. This is quite commonly what we see now that the population is aging across the world. An 82-year-old lady with a fall at home has got a fracture of neck of femur with comorbidities of being hypertensive, diabetic, previously had 2 stents put in the heart, and also, of course, COPD. Now, this is a patient who comes to the emergency and the anesthetist is called saying that, yes, this patient needs surgery, please come and see. So what does the anesthetist do? What happens now? Now, let's take the first phase, which is the preoperative phase. Now, in the preoperative phase, the anesthetist does what is called as a preoperative assessment. Now, this is extremely important, a very crucial step when we talk about patient safety in the perioperative period. This paper, which came out in Lancet way back in 2003, reiterated the facts that why should we do perioperative assessment? Now, the questions of why, how, by whom, and what can be expected has been addressed in this paper, which is a common training exercise for all the postgraduates when they start their training. And also they talk about what tests to select and the effectiveness of the preoperative evaluation. The main thing here, as you can see, which I've highlighted, is a thorough clinical preoperative assessment of the patient is more important than routine preoperative tests, which should be requested only when justified by a clinical indication. Now, in the present age and day where tests are being prescribed quite widely and rampantly, we need to understand that the anesthetist's initial assessment is more important than ordering the tests. So what happens in a preoperative assessment? There is a comprehensive evaluation, which includes history, examination. Then we stratify the risk as to where this patient falls in the risk spectrum. Then, if required, we take multidisciplinary inputs from physicians or cardiologists or neurologists as it's necessary. And of course, we do a little bit of optimization if the patient has to be optimized, and then we give some instructions. Now, there are guidelines for this. We have the Indian Society of Anesthesiologists Preoperative Investigations Guidelines, which guide us as to what needs to be requested as preoperative tests. Then we have risk assessment tools which have been validated. The most common and popular one is the American Society of Anesthesiologists, ASA grading. Of course, we have the other cardiac and other pulmonary related risk scores. Then we have risk prediction models, which actually predict how risky the procedure is for this patient. So one of the commonest things which people do use is something called as the ACS NSQIP, which is the American College of Surgeons. This is available online, and the patient data can be entered and a risk score comes up. The other thing which is more important here in the preoperative assessment is fasting guidelines. Now, why is fasting important? Now, fasting is important to prevent a complication called aspiration. Now, aspiration can occur when the protective reflexes which protect our airway is lost during anesthesia. So it can lead to soiling of the lungs and later leading to aspiration pneumonia and its sequelae. So there are again guidelines for this. The Indian Society of Anesthesiologists has got its own guidelines, and also the bigger societies like the American Society also have a guideline for this. The other thing which comes with fasting is also to ensure that the patient continue their medications, what they're taking at home, and also knowing which medications to stop. So again, there are guidelines. There is a lot of data available as to what should be continued. I'm just giving a couple of examples of guidelines which have been issued by local trusts and local hospitals. Now, this is what it would look like. So it would tell which one to continue, which one to discontinue, and what are the different medications which we need to keep in mind when it comes to interactions. Now, here we need to note again that if a person is undergoing a spinal anesthesia or an epidural anesthesia, there are some drugs which are used as antiplatelets or anticoagulants, which again should be withheld. So these are all things which an anesthetist takes care when it comes to preoperative assessment. Another important step here with risk reduction is consent process. Now, all of you are aware what a consent is. And when it comes to a preoperative consent for anesthetist, the anesthetist should explain the procedure and risks. He should again review the medical history, make sure it is the right patient, he's got the right notes for it. He should discuss the alternatives, and he or she should encourage questions and make sure that the patient has cleared all his or her doubts when it comes to anesthesia. And finally, the document should be kind of read by the patient, and the patient should sign the consent with the witness. So this is what happens in the preoperative phase. Now, the patient has undergone everything and comes to the operating theater. Now, what does an anesthetist do here to reduce the risk and improve patient safety? So let's start with something that is very familiar to every anesthetist and is a very good friend to every anesthetist, which is anesthesia machine. Now, anesthesia machine is something that is quite complex, and it undergoes a lot of checks before it is deemed safe to be used in the morning when we start the list. So we have guidelines for this. So this is an example of a checklist from the Association of Anesthetists of Great Britain and Ireland, which talks about how we should be performing a machine check. Then we have medications. Now, medications is again something that we use as anesthetists for every case, and we use probably the strongest medicines known to man, which can cause a lot of harm. So medication errors is something that we try to prevent in everyday practice, but still errors persist. So there are a lot of guidelines which have come out and a lot of recommendations. But again, we need to know the different categories of medication harm. This itself is a talk by itself. But I'm just going to highlight a few things that medication errors can range in a spectrum which can cause no harm to patient death. So we need to know what kind of a medication it is and whether we can give it in the specific route that it is prescribed for. And there are a lot of recommendations, again, a lot of papers which talk about how we should do. Just to give you an example, the label on any drug or ampule or syringe should be read carefully before a drug is done. And we know that this is one of the NABH standards, JCA standards for safety, and it is something that is strongly recommended. So similarly, syringes should be labeled always or almost always. So these are all the things that we use in medication safety. Again, here we are looking at various steps of pre-operative and intraoperative phase of medication errors and how to circumvent it and make it safe. We also have color-coded labels, which are again standardized, which can be used on syringes so that we don't give the wrong drug to the patient. Now, coming to rushing and urgency, all of us seem to be rushed and things doing in urgent way because of the lives. Now, why do we rush? Now, human nature is that we want to get jobs done quickly, and we grew up as kids to be told to accomplish as much as we can. And we think doing things fast will give us more time to do things that are enjoyable. And if you look around, we'll see that everywhere there is a message somewhere which says that don't rush. And one of the things that happened in anesthesia practice and surgical practice is the change which this gentleman brought about. This is Dr. Atul Gawande, and his book, The Checklist Manifesto, changed a lot of things. And way back in 2007-8, the change started happening, and it was based on this, which is the surgical safety checklist. So anesthetists, surgeons, nurses in the OT have to follow surgical safety checklist, and this has made a huge difference coming to the patient safety when it comes to errors. Now, coming to what about monitoring inside the operating theater? Again, there are standards for this. Now, the first thing regarding monitoring is that a qualified anesthesia personnel shall be present in the room throughout the conduct of a general anesthetic, regional anesthetic, or monitored anesthesia care. So this is something that has to be followed. And only after this is fulfilled, then we look at what can be monitored, whether it is patient's oxygenation by using FiO2, which is inspired oxygen concentration, or the SpO2, which is the pulse oximetry, ventilation, looking at clinically, looking at end-tidal carbon dioxide or a disconnection alarm, circulation, looking at ECG, blood pressure and heart rate, or temperature. So these are all things which have been recommended as standards of basic anesthesia monitoring. Now, is it the same across the globe? Now, if you look at this paper which came out from the Anesthesia Patient Safety Foundation, they looked at the recommendations regarding monitoring from the US, from the UK, from Europe, then Hong Kong, then also the WFSA, which is the World Federation of Society of Anesthetists. And what they found is that the monitoring standards for parameters that describe cardiopulmonary system are mostly consistent. But when it comes to some of the other things like measuring the state of consciousness, there can be a little difference in the recommendations by these societies. Now, we are competing with another thing which draws our attention in the operating theater, which is the mobile phone. So this can affect the safety of the patient. So what are we doing as anesthetists to circumvent this? Now, the Anesthesia Patient Safety Foundation addressed this in a very big way in 2017, looking at distractions in the operating room. And they said that we should have something like a sterile cockpit measure where during critical phases of the procedure, which could be intubation, extubation, giving a spinal anesthetic, we should make sure that there is no disturbance. And they also recommended that we silence the ringtones on our mobile phones and keep the telephone calls to minimum and brief as possible. So coming to how this can impact, distraction can impact, another important area here is intraoperative communication. Now, we all know in our training that we are trained with an SBAR communication mnemonic, which is based on how we report the situation, the background, the assessment of the condition, and the recommendation. But more importantly, in the operating theater, a closed loop communication is very important between the anesthetist, the surgeon, and also the nursing staff or the technicians. And how do we improve the intraoperative communication is by using simulation-based training. Now, types of anesthesia, again, all of you are aware, I'm not going to go into the detail, but we pick the best, safest anesthetic for the patient and we discuss it with the patient. So if a patient is safer under regional anesthesia, we describe that as the best anesthetic for him or her. And if general anesthesia is safe, then we describe that and recommend that. And we have, again, advances in this, wherein we have total intravenous anesthesia, which has made a lot of conditions safe, and regional anesthesia with ultrasound. Post-operatively, again, it's an important phase for an anesthetist. So it starts with the recovery room, and the patient is discharged from the recovery room only after fulfilling what we call as a Aldrich score or a modified Aldrich score. And this score has to be more than 9 for safe discharge from the PACU. Now, once they are in the post-operative phase, the common things that actually trouble a patient are either airway-related, respiration-related, cardiovascular, pain, or gastrointestinal. So we see all these kind of systems affected and the patients having issues because of that. And one of the things which has made a difference in our hospital is something called as the patient remote monitoring, which is the system that we use here called DOSI. It is a monitored bed where the patient's vitals are continuously monitored 24/7. And this is how we actually have a command center and how the beds are actually being commissioned here. And if we see what has happened, we have actually had zero code blues in the first 6 or 7 months since introduction. And you can see that we've been able to pick up a lot of these patients early on, as you can see the code oranges here. So one of the advances which we will probably see in the next few years going ahead is monitoring these patients remotely and better in the post-operative period and affecting the morbidity and mortality. Coming to human factors, again, we know that fatigue, stress can affect an anesthetist's performance, biases can affect, and of course, a lot of other non-technical skills, as we call it as ANTs, anesthesia non-technical skills. So these are all things which can affect patient safety. I'm not going to go into the details of this, but I'm going to talk about just one thing, which is called borderline tolerated conditions of use. Now, you look at the graph here, the BTCUs are nothing but actions which were initially considered as legal, slowly moving to an area of being illegal normal. So to give you an example, there is something which we do routinely, like waiting for the surgeon to come and be there at the safety checklist, timeout. We realize that, the surgeon is coming a bit late, or he calls up and says, why don't you start the case? I'm on my way. And we start being in this illegal normal area where we agree, okay, fine, there is a demand to finish the list. So let's kind of start the case. It's okay, he's on his way. Then after a few days, what happens? We reach the area where it becomes illegal. That is, the surgeon is probably in his clinic somewhere, and we still have started the anesthetic, for the patient. Something goes wrong as anaphylaxis, or it could be something else going on. Patient is having an issue, surgeon is not around, so it becomes an illegal issue. I'm just giving an example. Now, why this is important, the BTCU, is that it is first seen as a benefit and not a risk to enhance the performance of the system or the individual, and tolerated by the senior management. And a lot of variety of informal safety measures are used to kind of circumvent this. But as it goes, it actually creates a problem. And it is not picked up by incident reporting systems, and there is a slow drift. So here, the solution here is that we need to identify that this is happening, set realistic goals, and identify individuals who are more prone to violations. So this is something which I wanted to discuss because it's not something normally discussed when we talk about human factors. Now, coming to technology and advances.
The last 2 minutes, sir. Sorry to interrupt.
Thank
you. 2 minutes more.
I'll be done. So the artificial intelligence is something that we are seeing. Again, preoperatively, there's a lot of papers coming out with airway assessment, predictive analysis of risk, precision medicine. Intraoperatively, we are already seeing ultrasound technology coming in, which identifies nerves, and a lot of data coming out of predicting hemodynamics. And postoperatively, again, prediction of which patient will actually deteriorate or the pain requirements in the post-op period. So the other advances that we are seeing is in simulation and simulation training across the globe. Training education also is taking a big leap when it comes to improving safety, because we are continuing more of CMEs, more of workshops, training youngsters, life support courses which are being made mandatory, and of course, interdisciplinary training which is happening. An example is this seminar where a lot of technicians I'm sure have joined, and a lot of other non-anesthetists are attending this. So the challenges for our patient safety is one, as Dr. Anita was mentioning, resource limitations in a country like ours, cultural barriers, and also a resistance to change. So I think we need to overcome all this if we have to improve the safety. So in summary, what I would like to mention here is the anesthetist's role in patient safety can be divided broadly into preoperative, intraoperative, and postoperative, which I've just touched upon because this topic itself is a day-long CME. And we need to look forward to improving communication, education, and adopting innovative technology to improve the safety. And finally, I would like to leave you with this one graph, which is common not for anesthesia, but for the entire fraternity, that we need to balance knowledge and conviction in a way that we remain humble in this line here, which is called the humility sweet spot. And we have to be not too arrogant about what we know and not too insecure at the same time. Thank you very much.
Thank you so much, sir, for your wonderful session. So,
thank you. Thanks a lot.
Yeah. Any questions from any participant? They can raise the question in the Q&A box.
Debatta, there's one question on the Q&A. You'll have to refer to the Q&A for the question. I'll just help you out in this case. Sir, one question is there. It's asking whether do we have any Indian minimum standard monitoring requirement?
Yes, so the international guidelines, as I mentioned, the 5 different guidelines, which was mentioned in the newsletter, they state more or less the same when it comes to cardiovascular, when it comes to respiratory system, and the requirements for monitoring. And we also have the NABH standards, which is there actually in the NABH standards as to what needs to be as a minimum monitoring and how frequently should the monitoring be done. So everything is clearly defined. So it is there in our Indian system.
There are other questions. They are more referring about possibly that can be answered offline because it talks about requesting for some references for BTCUI and risk stratification modules. Sir. We can possibly take it offline, sir.
So thank you. We'll do that. Yeah.
What do you, Debatta?
Yeah. Thank you, sir. Thank you, Dr. Subin.